Now we're going to move on to cirrhosis. So cirrhosis is a chronic progressive disease of the liver, which causes a characteristic extensive degeneration of the liver's cells. These cells attempt to regenerate, but it's not in an organized fashion, which results in disruption or a dysfunction of the blood vessels and or the bile ducts within the liver. These disruptions lead to poor cellular oxygenation or hypoxia, resulting in decreased the function of the liver. Cirrhosis has an insidious, prolonged course. Now in this picture here, you can see that there is a normal liver on the left-hand side, and then you can see a cirrhotic liver on the right-hand side, just to get an idea of what that looks like and how you can see the cells in the liver that have been damaged on the right-hand side. Now, the potential etiology for cirrhosis would be long-term dysfunction of the liver, alcoholism, and non-alcoholic fatty liver disease. Excessive alcoholic ingestion is the single most common cause of cirrhosis. Did I record that? Approximately 20% of hepatitis B and 10 to 20% of hepatitis C patients will go on to develop cirrhosis of the liver. Now, in the picture that I'm showing now, this shows you the stages of liver cirrhosis. So stage 1 here showing how you start out with a healthy liver and then you wind up with some scarring, but very few symptoms. Usually the onset of cirrhosis is insidious, but occasionally there may be an abrupt onset of GI symptoms. Things such as anorexia, dyspepsia, flatulence, nausea, vomiting, and a change in bowel habits like diarrhea or constipation, all of which is a result of altered metabolism due to decreased liver function. The patient may even complain of right upper quadrant dullness or heaviness. Fever may also be an early manifestation. Now, stage 2 is where you've got a worsening of the problem. Usually there is worsening portal hypertension, which we'll discuss further in detail in a little bit, and the development of varices as well, such as esophageal varices. And stage 3 of cirrhosis involves the development of swelling of the abdomen, as you know, ascites, called ascites, and advanced liver scarring. So this picture here shows you the different levels and how the growth of the connective tissue destroys liver cells. Now this just reiterates the possible causes of cirrhosis, including, as we discussed, alcoholism, the hepatitis, chronic hepatitis, post-necrotic or acute viral autoimmune issues, malnutrition, environmental factors, and genetic predisposition. And this is a real good picture here of what jaundice looks like, especially as you can see it in the white of the eye, where that looks very yellow. So the clinical manifestations include ascites, which may disrupt kidney function and fluid and can become infected, resulting in spontaneous bacterial peritonitis, enlarging spleen, sequesters platelets, lowering count, which then interferes with the clotting function. Also, a failing liver produces inadequate clotting factors and increases risk for bleeding. Late-stage cirrhosis of the liver become unable to excrete bilirubin, which causes yellowing, like I said, of the skin and of the eyes, like we just saw in the picture. Toxins accumulate in brain, also resulting in hepatic encephalopathy, which can be characterized as delirium or even coma in the late stages. So for cirrhosis, here's early and late sign diagram as to what you will see. So the varices and portal hypertension continue to worsen. You can see some spider nevi, muscle wasting from malnutrition, bruising or petechiae, splenomegalia with portal hypertension. So initially you'll see vague symptoms such as GI symptoms, an enlarging liver, and then later you're going to get your thrombocytopenia due to the clotting problems, portal hypertension. You'll also get an increase in aldosterone, dark urine, and clay-colored stools. Splenomegaly also causing hematologic panel problems, such as a PT time increased. You can also see nosebleeds. You can also have hypotonia, peripheral neuropathy, and rickets secondary to vitamin D deficiency. So these are all of this in this diagram are all symptoms that you can see. A lot of these are kind of the later stages. But again, initially you may just have GI symptoms. Also, peripheral neuropathy, especially in alcoholic cirrhosis due to deficiencies in thiamine, folic acid, vitamin B12. You can also wind up
Asterixis, also known as the flapping tremor, and it's seen in various conditions such as cirrhosis, hepatic encephalopathy, opiate overdose, acute liver failure, and Wilson's disease. What you're going to want to have is your patient in front of you with their wrists extended, back like so. The physician will then take their hands and push back in the patient's hands, further extending them, and look for almost like a clonus-type movement, an uncontrolled flapping tremor, which may be symmetric in both hands or asymmetric. You want to know how long this lasts, its amplitude, and its frequency in your note.
hypokalemia is also a problem with liver when the liver is failing and unable to metabolize aldosterone, leading to hyperaldosteronism, which is sodium and water retention and excretion of potassium, which leads to the hypokalemia. As a result of the liver's inability to synthesize albumin, hypoalbuminemia, causing decreased ionic pulling pressure within the vessels, allowing fluid to leak out of the vessels, causing edema. So that's the reason for your edema also. The endocrine, normally the liver metabolizes the endocortical hormones such as estrogen and testosterone. So a male patient with cirrhosis may exhibit gynecomastia, which is breast formation, testicular atrophy, and decreased libido. Young women may experience amenorrhea, and in older females may have vaginal bleeding. Also, there can be skin problems, spider and angiomas, such as small dilated blood vessels with bright red center point and a spider-like branches occurring. A lot of times you'll see that on the face, such as the nose, cheeks, upper back, chest, and shoulders. Also, palmar arrhythmia, which is red area that blanches with pressure areas located on the hands and feet. Both of these conditions can be attributed to the increase in circulating estrogen. Other possible skin conditions can be purpura, which is a rash caused by superficial leakage of red blood cells, petechiae, which are small, about 1 to 2 millimeter, red or purple spots on the skin caused by a minor hemorrhages related to broken capillaries, and caput medulla, which is superficial engorged veins around the umbilicus. So for diagnostics, how cirrhosis can be diagnosed, generally the first thing will be you will get labs. Liver labs include AST, ALT, ALK Phos, CBC, total protein, albumin levels, bilirubin and globulin levels, cholesterol levels, Hep B and C levels as well. Now I want to go through what each of these lab values means when it comes to cirrhosis. So the ALT is an enzyme found mainly in the liver. Values are increased with all types of liver injury or cirrhosis. Then you have AST, an enzyme found in the liver also and other organs. AST is elevated in people with liver cirrhosis. Then you have ALP, which is an enzyme found along the bile ducts. ALP is usually normal or mildly elevated. Total bilirubin, a substance produced exclusively in the liver, as we discussed, it is increased with many liver diseases. Bilirubin is usually normal or slightly elevated until cirrhosis becomes far advanced. Albumin, a protein made by the liver that is often decreased in cirrhosis. And then you have your CBCs, which may be ordered to check the white blood cells and platelets. Anemia may be present if bleeding has occurred, such as esophageal varices. The platelets are often decreased with cirrhosis. That's why there's bleeding issues. PT time, you're going to check in INRs. Most clotting factors are produced by the liver. This test evaluates clotting function and results may be prolonged with cirrhosis. Then you go on to your liver ultrasonography to see, generally you'll see an enlarged liver. You'll do a liver biopsy. Elevated ammonia levels are usually later in later stage cirrhosis, and so is elevated creatinine. Now, in this picture that we have here, this is a picture of a liver biopsy. And generally what they do is they make a tiny incision between the ribs, and the needle is inserted in order to reach the area of the liver where the tissue sample is taken. The procedure requires a local anesthetic. So for a nurse standpoint, beforehand they're going to get all their labs to see where they stand with their platelets, CBC, all of your usual liver tests. And then post-procedure, they're going to look, you're going to need to take vitals, frequently initially. You're going to watch for bleeding. The biggest risk after a liver biopsy is hemorrhage. And then you want to also look for any infection too. So the most important thing is placing the patient on the right side, since that is the side of the liver, to keep the pressure, and that way it decreases the risk of hemorrhage. So after cirrhosis has been diagnosed, generally you can wind up with many different complications associated with the disease. Those complications can include portal hypertension, esophageal and gastric varices, peripheral edema, as we discussed some in detail, abdominal ascites, hepatic encephalopathy, and hepatorenal syndrome. So each of these has its own set of complications and nursing interventions that need to be taken into consideration. So with portal hypertension, this condition develops due to the structural damage caused by cirrhosis, which can result in compression and destruction to both the hepatic and the portal veins within the liver. This decreased blood flow through the portal system results in engorgement of blood vessels known as portal hypertension. The major complication of portal hypertension includes esophageal varices, which accounts for 80% of all the varices, or gastric varices, peripheral edema, ascites, hepatic encephalopathy, and hepatic syndrome. The clinical manifestations occurring include, with portal hypertension, are collateral circulation issues, trying to reduce the pressures associated with that. Varicocele occur as a result of collateral and venous systemic circulation issues, especially in the esophagus. And then for collaborative care, there generally are different things you can do for the esophageal varices, which we'll get into in a minute. Okay, so esophageal varices, these are tortuous enlarged veins within the esophagus, stomach, and intestinal areas due to the increase in blood flow to the area. The increased blood flow results from diminished blood flow through the hepatic portal system, which is increased portal hypertension, which we discussed. Varices can rupture, leading to intense bleeding, which can be a clinical emergency, and they are also manifested in slow chronic bleeding as well. An abrupt bleed may occur as a result of anything that injures the vulnerable dilated vessels, such as swallowing a poorly chewed food or ingestion of coarse foods, acid regurgitation, nausea, vomiting, straining, and activities that increase intra-abdominal pressure. For slower bleeds, the patient may have hematotesis, which is the presence of blood in the emesis, or melena, which is black tarry stool due to the presence of old blood. Acute bleeds manifest as profuse hemorrhaging from the mouth and nose. Sandostatin and vasopressin, both potent vasoconstrictors, especially for the splenic arterial bed, to stop the bleeding. Because these medicines lead to decreased coronary perfusion and increased blood pressure, nitroglycerin is often given simultaneously. Supportive treatment may also include the administration of vitamin K, histamine 2 blockers such as Tagamet or Zantac, and proton pump inhibitors such as Protonix. There's also lactulose, which is a hyperosmolar substance that draws the ammonia into the GI tract and leads to diarrhea. You can also give neomycin, which is administered to decrease intestinal flora of the colon, but must be used with caution as it can be toxic, nephrotoxic. So off of YouTube, here is a picture of esophageal varices, and you can see they're bleeding right there. That is someone was doing a live picture of that so that you can really see what they look like and how dangerous they can be, because they can bleed very fast and you can lose a lot of blood. Now this diagram here shows you the treatment in relation to the level of the varices. So when you have small varices, as we discussed, generally you can do an endoscopy to see the bleed. You can give the medicines which we just discussed. And then as you get into the further where they're more complicated and there's been secondary varices, then you're looking at, you can try band ligation, balloon tamponade, or any other procedure tips or shunt surgery as a rescue therapy as well. So with esophageal varices, of course, tell the patient to avoid alcohol, aspirin for sure, non-steroid anti-inflammatories, screen for the presence of it with the endoscopy. You can use the beta blocker, Corguard or propranolol to reduce incidence of hemorrhage, beta blockers as we discussed, stabilize the patient, IV therapy, blood products if needed, drug therapy, which we already discussed. Now this is another logarithm here that just shows you what happens as you find if you do have the esophageal varices that are bleeding. So this patient generally gets transferred to the ICU, and then you can also wind up getting Stenstaken Blakemore tube. Now the Blakemore tube, it is used for esophageal and gastric variceal hemorrhages and cannot be controlled by an initial endoscopy and banding. So different types of tubes are available, but for this one, there's a tube that's inserted into the esophagus and stomach, and then there's actually 5 lumens. So it would be important to label each of the lumens. It is inserted as an NG tube via the nose or mouth and one inflates the gastric balloon to hold it in place. The second allows for inflation of the esophageal balloon that actually tamponades the bleeding, and the third port for gastric lavage or suction. Due to continual pressure against the nasal and esophageal mucosa, the balloons must be deflated for 5 minutes every 8 to 12 hours per policy to prevent tissue necrosis. You can also use a football helmet, which may be used to secure the tube and promote tension against the bleeding varices while preventing pressure buildup against the nasal mucosa. So here in this diagram, you're just seeing what's the most important things. Of course, secure the tube to prevent movement, which could occlude airway. And then with this type of tube, you want to make sure that you deflate every 8 to 12 hours for about 5 minutes to avoid that tissue necrosis. And make sure you label each lumen. Now, there's also a TIPS procedure, which is to reduce the blood flow in varices, which can eliminate it. once the TIPS procedure is done, the catheter is placed in the jugular vein and then threaded through the superior and inferior vena cava to the hepatic vein wall of hepatic vein puncture site. And catheter direction portal vein stents are positioned along passageway overlapping liver tissue and extended into both veins. So it's a complicated procedure, definitely intrusive. After insertion of this, the intrahepatic portal vein flow is now reversed and with the direction of intrahepatic flow towards the tips, basically shunting. It's a shunt. So now another complication with cirrhosis is ascites. The accumulation of serous fluid within the peritoneal cavity may sometimes be preceded by peripheral edema. It is often noted in conjunction with peripheral edema. The fluid also consists of proteins and electrolytes. Protein shifts from intravascular space into the lymphatic system within the liver. The lymphatic system is unable to remove the increased volume, and this leaks proteins and fluid leaking from the liver capsule into the peritoneal or abdominal cavity. And that's why you have ascites in cirrhotic patients, especially the later end stage. The osmotic pulling pressure of the protein-rich fluid pulls additional fluids into the peritoneal cavity. The resulting decrease of fluid within the intravascular space causes a decrease in blood volume and finally leads to a decrease in perfusion to the kidneys, which results in decreased urinary output. Now, hypoalbuminemia, the liver decreased ability to synthesize albumin, which results in decreased colloidal ionotic pressure. And then you've got the hyperaldosteronism, which occurs when hormone aldosterone is metabolized by damaged hepatocytes, causes increased sodium reabsorption by renal tubules. This retention, combined with increase in antidiuretic hormone in blood, leads to water retention. So a lot of complicated things, but in light of all of that, the abdominal cavity is what collects the fluid. Now, the main cause of ascites is portal hypertension. Portal hypertension is basically the reason for a lot of things that go wrong with cirrhotic patients. A decrease in the production of plasma proteins, as we discussed. The clinical manifestations of abdominal distension with weight gain. When ascites is severe, there may be an inversion of the umbilicus, abdominal striae, and distension of abdominal wall veins. Patients often exhibit signs of dehydration, such as sunken eyes, dry cracked mucosa, tenting skin, turgor, dark colored urine, a decrease in urinary output, and finally muscle weakness due to hypokalemia. Patients with ascites are also at risk of spontaneous bacterial peritonitis due to altered immune system functions. So collaborative care with an ascites patient focuses on sodium restrictions, of course. They would like to initially restrict them to 2 grams per day, but if ascites becomes severe, it may be decreased to 250 to 500 milligrams per day. Fluid is usually not restricted. Bed rest initially promotes diuresis. Salt poralbumin may be given IV to help pull fluid back into the intravascular space. Potassium-sparing diuretics, such as aldosterone or spironolactone, are given to promote diuresis. There's also the paracentesis, which is the procedure where they insert a needle into the abdominal cavity to remove excess fluid. That's actually quite common in the later stages of cirrhosis when someone has a lot of ascites. It's performed on a severe ascites, and it restricts movement of respiratory diaphragm and or severe abdominal pain. It is not a curative procedure and may need to be repeated. The patient should void prior to the procedure, placed in a high Fowler's position. After the procedure, monitor patient closely for signs of bleeding, surgical, or you can also a person can also get a peritovenous shunt inserted, which can reinfuse the trapped fluid within the peritoneal cavity back into the venous circulation, is another possibility. Now, hepatic encephalopathy. This is a very terminal neuropsychiatric complication of liver damage. It can occur in any condition in which the liver is damaged, causing ammonia to enter into systemic circulation, and then it crosses the blood-brain barrier and injures the cerebral tissue. Encephalopathy is a multifactorial condition associated with varying degrees of cerebral edema and changes in level of consciousness. Other causative factors include GI hemorrhage, constipation, hypokalemia, hypovolemia, infection, metabolic alkalosis, paracentesis, dehydration, and uremia. Okay. One of the main characteristics is the flapping tremors, the asterisks, which is the flapping tremors that we showed a little bit ago, especially noted in the hands when the arms are extended and the wrists are flexed. Other manifestations include changes in neurological and mental responsiveness, ranging from sleep disturbance to lethargy and finally to deep coma. There is a grading scale for severity of hepatic encephalopathy. So in this diagram, as you can see the diseased liver, you can see the toxins after the ammonia levels increase, and that is basically the round circle that goes around and causes the hepatic encephalopathy in a cirrhotic patient. So collaborative care, the main goal in management of hepatic encephalopathy is reduction of ammonia levels within the blood. There can also be lactulose, which helps pull the ammonia and fluids from the intravascular space into the intestines and results in diarrhea. Antibiotics such as vancomycin are used to decrease bacterial flora of the colon to prevent further production of ammonia. Nutritional therapy would include protein, may be restricted due to decreased ammonia production. However, these patients require high-calorie diets up to 3,000 calories per day. Malnourished patients, such as alcoholics, may require protein supplements in the form of branched-chain amino acids through enteral administration. Sodium is also restricted to prevent ascites or peripheral edema. So I just wanted to show this screen here. This is clinical manifestations of the hepatic encephalopathy. And as you see here, the different stages, you have stage 1 with the mild confusion. You're going to see mild irritability. As you get to stage 2, you're going to start to see the more personality changes, blindness sometimes, disorientation. Stage 3 will be your confusion, stuporous, seizures sometimes even, occasional aggression, and then stage 4 where you got your complete coma. Now this is also another complication is hepatorenal syndrome. So this a logarithm here just shows you that with cirrhosis you get your portal hypertension, which is at the base of a lot of the complications of cirrhosis. And then you get your vasodilation, which then reduces the effective arterial blood volume, which then simulation of the vasoconstrictor system, renal vasoconstriction, and then you wind up with hepatic renal syndrome. It is characterized by renal failure with advancing astomia, which is the presence of large amounts of nitrogenous waste products, especially urea, in the blood, and a BUN greater of 20 milligram per DL. So long-term management of a cirrhotic patient can include repeated endoscopies and banding ligations for any possible varices. You've got your drugs such as non-selective B-adrenergic blockers. I'm going to go through some of the medicines. And then you also have your portosystemic shunts. You can also have a liver transplant may be considered for patients, and they would go through, they may be considered for that if they're in the late stages of liver disease, of course. It is not indicated for patients with widespread malignant cancer. So here are some of the medicine treatments that can be administered, and I will go through these. The vasopressin can be used to increase renal perfusion by causing vasodilation of renal arterioles. Octreotide works by decreasing the amount of growth hormone to normal levels. It helps reduce the loss of body fluids and minerals by blocking the production of these hormones. Propranolol is a beta blocker. It works by blocking the action of stress hormones like adrenaline or noradrenaline. It slows down the heart rate and makes it easier for your heart to pump blood to your body. Lactulose can be used, especially in cirrhotic patients with high ammonia levels, because it breaks down into your large intestine and then draws water into the intestine. This softens the stool and lowers the ammonia levels. Neomycin is a antibiotic. It works by stopping the growth of bacteria in the intestines, and this antibiotic treats only bacterial infections. It will not work for viral infections. Magnesium sulfate, is used to increase magnesium levels, which increases water in the intestines. Vitamin K can be given because the body needs vitamin K to produce prothrombin, a protein and clotting factor that is important in blood clotting to reduce the risk of bleeding. Proton pump inhibitors such as Protonix help to decrease the symptoms of heartburn, but also to help prevent ulcers. And finally, diuretics, which help in reducing the edema and body fluid retention by flushing out salts out of the body. So now this last screen here, I'm going to just run through the nursing interventions that are important in cirrhotic patients. So with nutrition, of course, you want to measure your INOs. You want to monitor their weight, patient's weight, see if it's going up or down. Are we on the right path or not? Encourage eating. A lot of times nutrition is of a problem, especially alcoholic cirrhosis. Small, frequent meals can help a patient to get more in. Encourage mouth care. Better mouth care means less risk of bleeding, also less risk of infection. Refer to dietitian. They may also need possible TPN if they're not getting enough in intake. Fluid overload, again, you want to monitor your I's and O's. You want to check your respirations, listen to your lung sounds for any fluid retention or wheezing, rales, anything like that. Heart monitoring, you want to check to see if they're doing okay from that standpoint. Assess peripheral edema, and then measure abdominal girth, see if they are continuing to retain water, and if so, or if they're starting to go down, you can see that. Monitor labs, restrict sodium, of course. Altered skin integrity, you want to make sure you're inspecting the skin pressure points, reposition regularly, elevate the legs, also clip fingernails so that they're not going to dig into their skin. After urination or bowel, make sure that you do clean thoroughly, and lotion, massage also helps. For breathing, you want to make sure that you are checking your lung sounds again, check your level of consciousness. The head of the bed should be elevated. Monitor ABGs. Provide some supplemental oxygen if needed. Make sure that you're encouraging the incentive spirometer. And then occasionally they may need paracentesis to relieve some of the pressure on the lungs from the fluid in the abdomen. These patients are at risk of injury, so you do want to assess to make sure that they are not bleeding and have a GI bleed, which then gets them weaker and weaker. You want to make sure that they use a soft toothbrush when they are brushing so that they do not cause any further bleeding. Avoid straining because varices can wind up rupturing. Monitor H&H and clotting factors. Observe for any petechiae, and also look at your vomitus and your stools for any blood in there to see if there's a bleeding issue. For mental status, you want to make sure you're observing behavioral change, speech, sleep, rest, presence of any foul-smelling stool or mouth, breath. Try to provide a quiet environment, and safety precautions are also very important with these patients. Thank you.